Moving from a mechanical issue back to a multifaceted genetic condition, let's explore Noonan syndrome, NS. This one affects multiple organ systems, right?
It absolutely does, and it's quite common for a genetic disorder with an estimated incidence of 1 in 1,000 to 1 in 2,500 live births. NS is characterized by a specific constellation of features: short stature, distinctive facial characteristics, developmental delays, and crucially, cardiovascular abnormalities, including congenital heart defects. Initially, it was sometimes called male Turner syndrome, but is correctly redefined in 1963 by Noonan and MK as its own distinct disorder.
What's the genetic root of such widespread effects? How does it impact so many different parts of the body?
NS arises from a disruption of the rasmapahinase signaling pathway. Think of this pathway as a critical communication network within cells, triggered by various factors and essential for organ development, synaptic adaptability, and cellular growth. It's fundamental. It's caused by mutations in several genes involved in this pathway, with 80–85% of cases attributed to genes like PTPN11, SOS1, RAF1, and CREAS, among others. Because this pathway is so central to development, disrupting it has these broad effects. It's an autosomal dominant disorder, often from new mutations. Clinically, hearing abnormalities are present in about 25% of patients, mainly affecting high frequencies. Congenital heart disease affects up to 90% of NS patients. That's a huge proportion. The most common heart defects are pulmonary valve stenosis, affecting 25–75%, and atrial septal defects, seen in 4–57%. Other abnormalities include ventricular septal defects, mitral valve defects, and aortic coarctation. The craniofacial features evolve with age. Infancy shows a prominent forehead, low-set ear, short neck. Toddlers may develop macrocephaly and a broad nasal bridge. Adolescence brings an inverted triangular face and webbed neck.
Hair is typically fine and sparse in early childhood, often becoming curly later. Eye color is distinctively blue or green, and various ophthalmological abnormalities may be present. Infants may have feeding difficulties and developmental delays. Cryptorchidism is frequent in males, while females generally have normal fertility. Renal abnormalities, subtle bruising, and splenomegaly can also occur. It's really a head-to-toe condition.
Given the major cardiac involvement, what does the ECG tell us in Noonan syndrome? Are there specific patterns?
Yes. Patients with NS often exhibit distinctive ECG features. These include left axis deviation with a negative AVF, an abnormal RS ratio over the left precordium, meaning the relative sizes of the R and S waves are unusual, and abnormal Q waves. Historically, these were linked to heart rotation or structural defects. However, a key study by Ryemakers and colleagues involving 118 patients demonstrated that while 58% exhibited a characteristic ECG pattern, they found no statistically significant relationship between these ECG abnormalities and underlying structural cardiac defects. This suggests these distinctive ECG features may arise independently of structural heart abnormalities, possibly due to the underlying RASMA pathway disruption itself. These ECG abnormalities are also more prevalent in infants and young children. For diagnosis, echocardiography is crucial, revealing things like left ventricular hypertrophy, LVH, and associated anomalies like pulmonary valve stenosis and mitral valve dysplasia. Certain echo findings can indicate prognosis. A comprehensive blood panel assesses thyroid function and coagulation factors.
Abdominal ultrasound is recommended due to splenomegaly risk, and renal ultrasound for kidney abnormalities. Regular ophthalmologic evaluations are essential. Genetic testing is vital to differentiate NS from other similar syndromes.
With so many features, how is NS definitively diagnosed? Is there a scoring system?
Yes, Vanderburg and colleagues established a diagnostic scoring system with major and minor criteria. Major criteria include characteristic facial dysmorphism, specific cardiac defects like pulmonary valve stenosis, short stature, chest deformities, and family history of NS. Minor criteria include suggestive facies and other cardiac abnormalities, developmental delay, cryptorchidism, and lymphatic issues. Diagnosis is confirmed with characteristic facial dysmorphism plus 1 major or 2 minor criteria, or suggestive facial features with 2 major or 3 minor criteria. It's a structured way to integrate all the findings. The differential diagnosis is broad, including Turner syndrome, fetal alcohol syndrome, mosaic trisomy 22, Williams-Beuren syndrome, Costello syndrome, and others that share phenotypic features. Management involves a comprehensive, multidisciplinary approach across various age stages. It includes screening of multiple organ systems, monitoring growth and development, and providing targeted treatments and interventions as necessary for heart issues, developmental support, feeding problems, etc. It's really coordinated care over a lifetime.